welcome to 2026 Asian Cardiovascular Disease Web Seminar. Our chairman, Professor Jianping Li, will join us in about half an hour. So for this opening segment, I will serve as the temporary host. Today, sections focus on the adherence imperative in hypertension management, a highly practical topic for clinics care for hypertensive patients across Asia. It is my great honor to introduce our first speaker, Professor Thomas Weber. Professor Weber is from Australia. He is a well-recognized expert in hypertension and cardiovascular medicine, with rich real-world experience in blood pressure management. He will present on obstacles in hypertension control, addressing medication adherence and clinical tenure. Please join me in welcome Professor Thomas Weber. And Professor Li join us later for the panel discussion. Over to you, Professor Weber. Thank you.
So thank you very much, dear Professor Cheng. Dear colleagues, good evening to you. It's noon here in Austria, so good evening. And I will try to open my slides. I think you should see them. So thank you very much again for the invitation to this nice lecture on the topic of adherence and also inertia, which are of course very important obstacles in hypertension control, I would say globally. So that's basically where I'm come from. I live in Austria, which is in the heart of Europe, so to speak, and that's the hospital where I'm working, the old building and the new building. So I have some conflicts of interest, but the most important is that I'm the immediate past president of the European Society of Hypertension and the co-author of the ESH Hypertension Guidelines 2023. So that's the most famous quote on the topic, probably from a US person a while ago. So drugs don't work in patients who don't take them. I think this is obvious, but this is not an explanation how we can tackle the problem. So that's the agenda of my talk today, and I think we will go through it. And I hope you can follow easily, and then we can have, of course, a nice discussion. Let's start with adherence. If we want to understand something, if we want to discuss something in a scientific way, we need to have a common language. And these are the definitions. Drug adherence is the extent to which a person's behavior corresponds with agreed recommendations from a healthcare provider. And it starts with initiation. Of course, the patient has to take the very first dose of the medication, then implementation, which means that the actual dose corresponds to the prescribed dose. And sometimes it comes then to a discontinuation, which means that the next dose is omitted and there are no more doses taken thereafter. And the combination between the initiation and implementation is called persistence. And that's how it is in real life. That's a meta-analysis. And you see here of patients in hypertension, very many patients. So 10% or 5 to 10% don't even start with the first dose. And then adherence decreases over time. And after 1 year, this is here, roughly 60% or so remain adherent. And if you subtract those who don't take the dosage correctly, then you end up with some 50 to 55% of patients being fully adherent to antihypertensive drugs after a year. Is this a big problem? Yes, it is a big problem, and we learned a lot in studies where patients were investigated for potential renal denervation, and in many of these studies, chemical adherence testing, so chemical drug testing, was performed, and it turned out that if you summarize total non-adherence and partial non-adherence, the numbers were very high, so in most studies, up to, let's say, 50 or even 60%, some of them were better. So it's a very big and a very common problem we are facing probably all around the world. And if you split it up a little bit, so in patients undergoing renal denervation, it's 43% of complete and partial non-adherence. If it's patients showing up with hypertensive emergencies, 33%. If it's patient with resistant hypertension, again, 40% are complete or partially non-adherent. That's a big database from the Lombardy, which is the north of Italy, and it shows what happens after 5 years. And you see after 5 years, roughly half of the patients totally discontinued antihypertensive drugs for what reason soever. Some of them switched, some of them combined, but the majority actually totally stopped taking antihypertensive pills. And to make the story even more complicated, even in one individual, the situation may not be stable over time. These are data from a trial on renal denervation where chemical drug screening was performed, and these patients should be on antihypertensive drugs. And you see at the beginning baseline 62% were adherent, but then the numbers are more or less consistent, but some patients being adherent at baseline, even 10, it's a huge percentage, were incomplete or non-adherent at the 3 month visit, and some of them were fully adherent again, or some of them remained non-adherent. So it's even within one patient, the situation may change over time. Okay, again, if you want to understand something in a scientific way, we need to measure. And how can we measure adherence? So there are a couple of potential options. So it starts, of course, with the prescription of the drug. You see the doctor, you see the patient. Then the patient goes to the pharmacy to refill or to take the first prescription, to get the medications, and then to refill the prescriptions. Then he goes home and takes the drugs. And you can monitor this with electronic monitoring, or of course the patient can have a diary. Then he goes back sometimes to the doctor, and then what can you do? You can answer the patient, okay, what about your adherence? Do you take the drugs? You can use a formal questionnaire or interview. You can count the pills. This is often done in studies. You can perform witness drug intake in front of you, in front of a nurse. This is rarely done, maybe in studies. Or you can, of course, measure drug dosages in body fluids. So again, chemical adherence testing. And again, that's a nice summary. The methods to assess drug adherence, the direct methods, which is direct observation, very accurate when you see the patient swallowing the drug, but not feasible in daily clinical practice, of course. And you can do chemical adherence testing. It's a promising method, but I come back to this later on. You can estimate, okay, if the patient is on a beta blocker, he should have some kind of bradycardia or so. Not very accurate, generally overestimates adherence. You can use dedicated questionnaires. They are simple to use, but tend to be overestimated. Pill counts are done in clinical trials, so the patients bring the pills not taken back and you count them. Prescription refill data, this works very well, for instance, in my country. But of course, there are gaps now in electronic monitoring, etc. Patients can be outside of the systems and so on, then it doesn't work. And you can use electronic monitoring devices. So that's a pill box, and every time you open the pill box, it makes an entry. So you don't need it actually. You don't know actually if the patient took the drug, but at least it was possible, and at least you know when he does not take the drug, because then there is no opening of the pill box. They correlate quite nice. This is continuous electronic monitoring versus prescription refill records. And you see that the estimates of adherence were quite consistent with both methods. And that's these electronic pill boxes, which make an entry here, a blue dot, when the patient opens the pill box. And both patients, these were different patients, give you a good adherence. So more than 80% of the drug dosages are represented here. But of course, you see here, this patient is with very good adherence. Sometimes the timing of the day is not very accurate. Sometimes maybe 2 pills a day, but in general, adherence we would characterize as good. This patient, of course, has long days of drug holidays, and then on some days a couple of pills are swallowed. So although this patient took 80% of the drugs, we would describe this for sure not as a good adherence for whatsoever reason ever, maybe psychological reasons whatsoever. And then, of course, you can the chemical adherence testing, which means the patient comes to you and you know he's on 5 antihypertensive drugs. Okay, why not measure the drug levels in plasma or in urine, whatever you prefer? Well, yes, it's an attractive method. It's a snapshot on the one hand, and of course, you have to understand. You have to exclude gastrointestinal alterations. You have to exclude increased volume of distribution with edema or so. If you look then at the actual drug levels, you have to exclude a high level of in vivo metabolization of the drug and pre-analytical artifacts. So you have to understand a couple of things like basics here in pharmacokinetics. There are 3 plasma half-lives until you get a stable dose. That's the one thing you need to understand. The other thing is you need to know of all the antihypertensive drugs you see here. We can have a long list or so. What's then the minimal concentration at regular dosing intervals? Seems easy to implement with a computer or so in a lab, but it's not that easy as you would think. Here you see a proof of this. These are as a meta-analysis of 45 papers. These were pharmacokinetic studies on antihypertensive drugs. And the steady-state plasma trough concentrations were measured using chemical adherence testing with liquid chromatography tandem mass spectrometry. So that's truly the gold standard method. And what you see here is that you get very, very different results for the concentrations. Very much more different than you would have expected here for quite common antihypertensive drugs. So amlodipine, valsartan, hydrochlorothiazide. So these were common, but you see here, they are very different with different labs, with different dosages. And that's the mean trough concentration is here, but is this representative for this patient group, for this patient group? And if you then go into the details for amlodipine, the determinants of the dosage, of the concentration you found was the dosage. This is true. No determinant was sex, body weight, mean age. But if you look for hydrochlorothiazide, the dose, the drug dose, was not a significant, you see the p-value here, determinant of the plasma concentration you found. But age and body weight were the determinants. And if you look for valsartan, neither the dose nor age nor body weight were determinants or were related to a plasma concentration of valsartan here in this case. So it's not as simple as it might seem. Of course, if you want to start a program, and that's many people consider this now, at least in Europe, you have to ask the patient, a verbal consent should be obtained. The report then should be detailed in simple terms. The feedback of the result, of course, must be given. That's the idea behind. You don't need just to know what it is. You want to change the behavior of the patient, and you have to discuss with the patient. And there are other things you have to consider. Well, when you think about when you see a dentist, you on your own as a person, you see a dentist. Of course, you will clean your teeth before. That's clear. And when the patients know, you will assess drug levels in serum or in urine. Maybe he has not been adherent for 2 or 3 weeks, but before, on the 3 days before he has an appointment with you, with the doctor, he will take the medications. So it's a snapshot, and there's no guarantee that the rest of the time is also adherence is also present. Yes, and of course, if you measure with different adherence with different, let's say, methods, let's say you have a questionnaire, or you do an assay, which is drug testing, chemical drug testing. They give you a little bit different information, but if both are fine, you will have the lowest blood pressures, at least in this test of patients in an emergency room. Okay, but then that's fine. You have so many options. Well, we asked then the excellent centers of the European Society of Hypertension all across Europe, 67 centers, what are you using, guys? What are you using in clinical routine? And the only thing which is used is that the doctor asks the patient, are there any missed doses? Did you reduce the dosage? Did you change anything with the drug? But all the rest, questionnaires, blood or urine measures, etc., pill counts, nothing of this thing. You see here the percentage is done in clinical routine. What are then the predictors of non-adherence? Well, basically, this all seem logical. The presence of psychological problems, depression, cognitive impairment, of course. Then you need somebody who takes care of the patient. Treatment of an asymptomatic disease like hypertension, of course, is a predictor of non-adherence. Inadequate discharge, follow-up planning, side effects. This is very logical, and that's just the human behavior. That when the patient does not believe in the benefit of the treatment, okay, he will not take it, and so on. If it's too complex, makes a sense. And in some countries, or in many countries, also the cost of the medication may play a role. And then is the drug class, of course. And we know this from big surveys, let's again, and from Northern Italy, the lowest level of discontinuation you find with ARBs. And then here ACE inhibitors were the reference, and all the others have higher rates of drug discontinuation. You see again in this analysis, ARBs or ERBs in combination with anything have the lowest rates of discontinuation. We know this. And we also can note that within a drug class, the results related to discontinuation may be homogeneous, like here with ARBs, so all of them are quite good, or they may be quite different, as you see here. With CCBs, there are some with high rates and some with low rates of discontinuation. The same is true for diuretics. And then here, well, men have lower adherence as compared to women. People with already borderline, let's say, blood pressure or not so high blood pressures, and young people are less adherent than the others. And doctors think, yes, that patient beliefs affect their adherence. This makes sense. Concerns about medication affect the adherence of the patients. Yes, and it's possible to improve adherence. This is true. The clinical consequences of non-adherence are important. And basically what happens is that you will get the patients, the non-adherent patients, have a higher risk of cardiovascular events, as is shown here in young adults, for instance. So much higher risk, 50% higher, 2 times higher risk of cardiovascular events. And again, newly diagnosed hypertensives, they can lower the cardiovascular risk by 50% by being fully adherent. That's a number, that's a table showing you a number of cardiovascular problems which have been related to non-adherence, from uncontrolled hypertension, increased arterial stiffness, hypertrophy, up to myocardial infarction, stroke, and even all-cause mortality. Very recent in the SPRINT trial, an interesting pattern has been observed. Some patients are fully adherent. This makes sense. Some of them are under-adherent, which means that they don't take all of the drugs. Some of them are over-adherent, which is relatively novel, so they take more drugs than they should do, than it has been recommended. And some of it's really fluctuating, sometimes over, sometimes under adherence, sometimes adherence. And these with fluctuating adherence, you see here in this color, have really the highest event rates. How can you improve adherence? One of the biggest issues is, of course, time. And that's the time doctors in Europe spend talking with their patients, the majority 1 to 5 minutes. For sure, this is not enough, but that's how it is. That's a questionnaire among healthcare professionals. You can use very simple things. You have a multi-dose adherence package, like here, which is pre-organized from somebody else, and the patient just has to know when it's morning, midday, did you take the drug? Well, if it's not in, I took it. So, and with this, some colleagues could reduce even hospitalizations. Yes, and if you perform chemical adherence testing, and if you talk to the patients, and if you discuss the problem and detect, sometimes blood pressure will go down. That's a non-randomized trial. That's an observation study. And this is related to adherence. But if you try the same thing in the randomized trial, actually, so far, a couple of trials, you never found a real result. So for some reason, the benefits of adherence testing and discussion with the patients disappeared in the randomized trial. This was one from UK, this is one from Denmark, but the same finding, blood pressure was not better controlled. If you use single pill combinations, adherence will be better. Renal denervation has a specific place. You know, I know that in China, renal denervation, so interventional therapy of hypertension, is increasingly used. And the beauty of this is not just it's an intervention, but it's done once and it works for 10 years. And you see here just the results of one trial. Is the blood pressure lowering effect of renal denervation is always on. You can't escape once the intervention is done. And that's, of course, one of the beauties of these interventions. What then do the doctors do? I reduce administration frequency of the pills. I use single pill combinations. I think this is all recommended in the guidelines. I stop unnecessary medications. Yes, this makes sense. But all the other things are rarely done, honestly. I encourage self-monitoring of blood pressure. Yes, this, of course, does make sense. If you ask patients about adherence, you find that emotional aspects, exposure to family hardships, so significant psychological problems, have a significant impact on the risk of non-adherence. This was the result of another survey we did in excellence centers. And then finally, it's not always the patients. Sometimes it's the problem with the physician, with the doctor. And we call this problem inertia. So what was this? This was in the data from the US. This was a survey on GPs, on patient visits, where the patients had uncontrolled blood pressure. And what did they do? What does the doctor do? So with the result, with the sheet of the result of this visit, a survey was sent to the doctor and he was asked for a comment. So in these patients, all of them had uncontrolled hypertension. 50% did not recommend lifestyle modification. 60% of the doctors did not change the prescription medicine for hypertension. So the majority did basically nothing. And why was nothing done? So this was the answers to the questions. So the ones that said need to continue monitoring patients before changing drug regimen, okay, maybe. Some of them, 30%, were happy with the blood pressure, although it was still elevated. Then some said, 29%, the focus of the visit was not blood pressure control. So why care about the blood pressure? Some of them said diastolic reading was satisfactory, albeit systolic was elevated. Poor patient acceptance, 9%. Priority was improving compliance, 9%, etc. So there's always many reasons not to do the correct thing. And we try to do this. This was another interesting trial. So a retrospective cohort study based on electronic health records. Here again, prevalence of diagnostic inertia. This was after ABPM. So patients came into the office, had a high office blood pressure. They underwent ABPM without the prior diagnosis of hypertension. And in 44%, ABPM was elevated. So this was clearly hypertension. But strangely enough, in 31%, there was so-called diagnostic inertia. Hypertension was not diagnosed despite enough evidence. So high ABPM, high office blood pressure. This is hypertension. And that's therapeutic inertia. Again, these were patients with high office blood pressure, had an ABPM. They were treated already for hypertension, and 59% had a high ABPM. But out of these, almost 30% therapeutic inertia. So office blood pressure was high, ABPM was high, but hypertension treatment was not increased despite high ABPM. That's clinicians' inertia, or doctors' inertia. And that's a survey, big survey from the US again. And this is primary care visits with clearly high blood pressure, above 140 over 90. We're not talking about 130 over 80. and the established diagnosis of hypertension. And here you see the prevalence of hypertension treatment intensification. So when the doctors saw blood pressure is high and they did something. Well, what you see is it's low in 20% and it's decreasing, at least here over time, in 15%. The doctor did do something, and 85% were doctors' inertia. Nothing has been done. So what can you do about it? It's a problem failure of healthcare providers to initiate or intensify therapy according to current guidelines. It's gaining increasing attention, major cause of clinicians' failure to adequately manage hypertension, thus leading to an increased incidence of cardiovascular events. So the strategies in this review were, what can you do? Physician education, reminders, ABPM is important, then the doctor realized blood pressure is high, digital medication offerings, physicians' peers, so they will go through your patient list and ask you, why didn't you do anything? And of course, you can put the problem to the pharmacist and let him counsel the patients. You can do something and it will be effective at least in some amount in 40% of the patients or of the doctors. So the problem is with adherence and physicians and nurses, they come together in a way which is nicely depicted here. The inert physician prefer the apparent safety of immediate inaction, doing nothing, to the long-term benefits of treatment titration, which in their mind comes with immediate difficulties and potential side effects. Thank you very much for your attention.
Thank you, Professor Thomas Weber, and for your excellent presentation. It's truly outstanding lecture. Medication adherence plays a crucial role in clinical trial. And Professor Thomas analyzes the existing problems regarding medication adherence and outlined approaches for improving adherence in clinical life. Thank you very much.
Thank you.
And the second professor give me a new topic about adherence is me. I'm from China, Beijing Anzhen Hospital, the center of hypertension. Now my lecture is the importance of improving adherence in hypertension management. I will share my lecture. Okay, let me move this one. Okay. Here is our roadmap for today. We will cover two areas. First, what medication adherence really means and its clinical impact in hypertension. Second, how single pill combination therapy can improve adherence, including new clinical evidence on bisoprolol and amlodipine tablets in Chinese patients. Let's begin with the fundamentals. Let's start with definition. Medication adherence is the extent to which patients follow agreed treatment recommendations. The right timing, dose, frequency, and duration. The terminology itself has evolved. In the 1950s, we spoke of complying, which carried an implication of obedience and a passive patient. Adherence then replaced it, shifting away from physician dominance toward agreement and partnership, while concordance goes further still, treating the patient as an active decision maker. Between 2009 and 2012, the European ABC project proposed the framework we use today. Adherence has three phases: treatment initiation, when the patient takes that very first dose; implementation, how closely actually behavior matches the prescribed regimen; and persistence, how long treatment continues until it is discontinued. So, how do we actually measure adherence? The methods fall into two broad groups: direct methods, such as directly observed therapy, during concentration monitoring by mass spectrometry, and emerging digital sensor pills. These methods are accurate but often impractical outside the hospital, and some are not yet approved for antihypertensive drugs. Indirect methods are more common in daily practice. Patient self-report and questionnaire, like the eating risk scale, are simple and inexpensive, but they tend to overestimate adherence. Pill counts and pharmacy refill records are more objective but coarse. And electronic monitoring devices give real-time objective data, although offering a pill box does not guarantee the dose was actually swallowed. The key message is that every method has trade-offs, so we interpret adherence data with that in mind. The figure maps the factors that drive no adherence across those same three phases, with red box showing the causes and the dash box showing potential solutions. And initiation, the barriers include perceived disease severity, insufficient information, and poor communication, and these are addressed largely through education. During implementation, complex regimens, multiple tablets cost, and lack of follow-up or undermined adherence. And this is exactly where single pill combinations and structured support help most. And for long-term persistence, we see both unintentional barriers like forgetfulness and intentional ones like fear and refusal. Notice how often regimen complexity appears across these phrases, because that is precisely where the single pill combination can intervene. Themes that will return to repeatedly. Now, let's look at the reality in China. Across multiple studies using different tools, adherence among Chinese hypertensive patients is mostly below 50%. You can see the wide variation here, from around 20% up to the low 60s, depending on the setting and the measurement tool. The one clear outlier is the Shanghai community cohort at 83%, and that is instructive. Favorable economic condition, abundant medical resource, high health literacy, and an old population all push the adherence upward. But the take-home is sobering. In most settings, half or more of our patients are simply not taking their medication as prescribed. This is a problem we need to solve. And it is not patients who recognize this. In a telephone survey of more than 1,200 primary care physicians across 17 countries, poor adherence was the single most cited barrier to blood pressure control, named by 22% of doctors. That ranked well above insufficient monotherapy efficiency and 41%, and above inadequate follow-up. Those escalation side effects and delayed combination therapy. So, from the physician's chair, adherence is not a peripheral concern. It is the number one obstacle to getting patients to goal. That board consensus set up why the consequences matter so much. And the consequences are serious. This systematic review and meta-analysis qualify now adherence affect mortality, using the proportion of this covered, with good adherence defined as above 80%. In 4 studies with over 1.69 million patients, poor adherence raised cardiovascular mortality by 61%, a hazard ratio of 1.61. In 12 studies with more than 2.19 million patients, poor adherence raised all-cause mortality by 32%, a hazard ratio of 1.32. These are enormous populations with consistent forest plots. The message is unambiguous. Poor adherence is not just a number on a chart, it is cost lives. And that means improving it should translate into real, measurable benefit. And it does this. Starting with the short-term benefit. On the left, adherent patients had markedly lower blood pressure than no adherence patients. Systolic around 125 versus 140, diastolic 77 versus 89, and the mean arterial blood pressure was 93 versus 107, or higher significant. In the middle panel, mean arterial blood pressure fell steadily as the number of covered medication increased, a clear dose response with a correlation of minus 0.5. And on the right, good adherence significantly improved the rate of reaching blood pressure targets. So better adherence delivers immediately measurable improvement in control. The long-term benefits are equally compelling. This dose-response meta-analysis, together covering millions of patients, show a smooth continuous relationship between adherence and heart outcomes. For every 20% increase in adherence, the risk of cardiovascular events fell by 13%, a relative risk of 0.887. And for every 20% increase, stroke risk fell by 9%, a relative risk of 0.91. The relationship is continuous, so there is no single threshold that a patient must cross. Every incremental gain in adherence buys additional protection, which is a powerful and practical message of patients who feel their effort do not matter. So, how do we improve adherence? One of the most effective levels is the single pill combination. This large 2025 German claims analysis matched more than 25,000 patient pairs, starting either a single pill combination or a free combination. The result favored the single pill on every front. Adherence is significantly higher. Risk of death, myocardial infarction, stroke, transient ischemic attack, coronary artery disease, heart failure, and renal failure were all lower and statistically significant. And the total costs were lower, roughly 4,000 at 700 versus 5,000 at 700 euro per patient. Better adherence, better outcomes, and lower cost. That is a real trifecta, and it makes a strong case of simplifying therapy into a single pill. That concludes our foundation on adherence. Now let's turn to the second section, the practical solution. We focus on single pill combination therapy and specifically on new clinical evidence for bisoprolol amlodipine tablets in Chinese patients with hypertension. Why do combinations matter so much? Because most hypertensive patients simply need more than one drug. Clinical practice shows that at least 3/4 require 2 or more agents with different mechanisms of action to reach target. The landmark spring trial reinforced this. The intensive treatment group used a mean of 2.8 medications and got 90% of patients below 140 systolic versus 1.8 medications and 71% in the standard group. So combination therapy is not the exception, it is the rule. The real question is how to deliver several drugs without sacrificing adherence. And that is the central tension, because complexity itself erodes adherence. The Argentine Vatata study of more than 1,100 patients qualified the precisely. Taking 3 or more drugs versus fewer than 3 was associated with a 15% reduction in adherence, a hazard ratio of 0.85, and dosing more than twice daily versus twice or less cut adherence by 22%, a hazard ratio of 0.78. So every extra pill and every extra dose works against us. This is exactly the problem. The single pill combinations is designed to serve more drugs but fewer pills. Reassuringly, The guidelines are completely aligned on the answer. From 2023 through 2025, every major society recommends single pill combinations. The Chinese Primary Care Guidelines, the Chinese Hypertension Guideline, and the Chinese Expert Councils on Adherence, and internationally, the AHA, ACC, ESC, and ESH guidelines. The common themes are consistent. Simplify the regimen. Prefer initial two drugs single pill therapy. The use it is improve both blood pressure control and adherence while reducing therapeutic inertia. When Chinese and international guidelines converge this completely, it signals that single pill combinations are the emerging standard for combination therapy. Yet, there is a striking gap between guideline and practice. Real-world Chinese data show that monotherapy still dominates at 78% of prescriptions. The 2024 Hypertension Center Quality Report, converting more than 4 million patients, found combination regimens at 57%, but single pill combinations made up only about 30% of those. And the China Status Survey found that just 12.7% of patients started treatment on a single pill combination. So, despite strong evidence and unanimous guidelines, real-world uptake remains low. Closing this gap is a genius opportunity, and it needs solid local evidence, which brings us directly to our study. That evidence is now here. This is the first national multiple-center interventional study of a bisoprolol amlodipine single-pill combination in Chinese hypertensive patients. It was led by me, my team at Beijing Anzhen Hospital, and other multiple hospitals nationwide. And it was recently published in the GCH, the official journal of the World Hypertension League. Until now, clinical application data for this particularly combination in the Chinese population was lacking. This study fills that gap. Let me walk you through this design and its findings. First, the background and objective. Hypertension prevalence is rising in China, so combination therapy has become an essential strategy. The bisoprolol amlodipine single pill combination is promising for controlling both blood pressure and heart rate and for improving adherence. But the Chinese clinical data have been limited. The objective was therefore straightforward: to evaluate the efficiency and safety of the bisoprolol amlodipine single pill versus free combinations in Chinese patients with uncontrolled essential hypertension. Here is the study design. This was a study of 78 patients with uncontrolled hypertension, defined as official systolic of at least 140 or diastolic at least 90, together with a resting heart rate of at least 70 beats per minute, who were already on free combinations of a beta block plus a calcium channel blocker. After a 4-week washout, they were switched to the bisoprolol amlodipine single pill at 5/5 milligrams. The primary endpoint was the change in office systolic blood pressure from baseline to 12 weeks. Secondary endpoints include office, home, and ambulatory blood pressure, time in target range, adherence, and adverse events assessed across the scheduled visits. Briefly, the baseline profile, the patients averaged 49 years of age and were about 73% male with a mean body mass index of 26. Their baseline office pressure was 141.7 over 92.6 millimeter mercury, confirming that they were inadequately controlled on their prior regimen. So this is a typical real-world populations of patients who are not at goal, the group in which we need better options. Now, the results, and this is the heart of the study. On the single pill combination, office blood pressure and heart rate fell substantially at weeks 4, 8, and 12, with the largest reductions at 12 weeks. Systolic dropped by 13.9 millimeter mercury from 141.7 to 127.8. Diastolic fell by 11.2 from 92.6 to 81.4. And heart rate fell by 11.3 beats per minute from 82.3 to 71, all highly significant with p below 0.0001. Just as important, time in target range improved dramatically. Mean clinical time in range rose by 47.9% points, and the proportion of patients with time in range above 70% climbed from 19.2 to 66.7%. So we achieved control that was both deeper and more stable. These benefits carried through the home measurement, which reflect everyday life. After just 1 week, home blood pressure and heart rate had already fallen significantly, an early and reassuring signal of patience. By weeks 5 and 9, they fell further and steadied down. By week 9, home systolic was down 6.6 and diastolic down 4.2 millimeter mercury, with heart rate down 5.5 beats per minute. This rapid onset matters clinically because patients who see their numbers improve quickly at home are much more likely to stay engaged and adherent. Ambulatory monitoring, our most rigorous measure, tells us same story. After 11 weeks, 24-hour blood pressure and heart rate were significantly reduced, overall by about 4.3 systolic, 3.2 diastolic, and 4.8 beats per minute. And the reductions held across every period, daytime, nighttime, and importantly, the morning, where pressure fell by 4.6 over 4.5 millimeter mercury. That morning effect is clinically valuable because the early morning surge is when cardiovascular events tend to cluster, and controlling it is a particularly strength of this combination. Single pill also improved time in target range on ambulatory monitoring. Overall, 24-hour time in range rose significantly after 11 weeks, with systolic about 10 percentage points and diastolic up more than 12. And the gains spanned both daytime and nighttime. For example, nighttime diastolic time in range jumped from 38 to 50%. higher time in range means blood pressure stays within goal for more of the day and night, and that sustained control rather than a single good office reading is what accurately protects the organ over time. Finally, adherence and safety, the reason we start this whole journey. Adherence measured by tablet count was excellent. 96% of patients achieved good to excellent adherence after switching to the single pill. Tolerability was equally reassuring. There were only 6 adverse events in 6 patients, about 8%, all mild and self-resolving without any special treatment, and no patient discontinued because of an adverse event. So the single pill delivered strong efficiency while being very well tolerated and easy to stay on. Persistently, the combination of benefit we are looking for. Let me pull the conclusion together. The bisoprolol amlodipine single pill produced rapid, substantial and sustained reduction in both blood pressure and heart rate in Chinese patients with who inadequate controlled on free combinations. 3 implications stand out. First, it provides real-world Chinese evidence for these combinations. Second, it delivers effective dual control of blood pressure and heart rate with a distinctive advantage in morning blood pressure, which is especially valuable in patients with sympathetic overactivation. And third, switching from a free beta block plus calcium channel blocker combination to the single pill improved adherence, and through better time in target range, supported sustained and stable control. In short, simpler treatment, better adherence, and better outcomes. To summarize in these 3 points, poor medication adherence remains a major and frequently underestimated challenge in hypertension management, one that raises the risk of cardiovascular events and death. Guidelines worldwide now recommend single pill combinations to simplify treatment, improve adherence, and support better blood pressure control. And our new Chinese evidence shows that the bisoprolol amlodipine single pill delivers effective blood pressure and heart rate control, improved time in target range, and excellent adherence. Thank you very much.那个李教授上来了吗？好的，now I'm go on. Let let me introduce the 2 professors from China. The first one is I can't not see the lecture. Okay. First is Professor Professor Ni Li. Tongji Hospital, Tongji Medical College. She is associate professor cardiology department, Tongji Hospital, Tongji Medical College, Huazhong University of Science and Technology. The next one is the next professor is. Oh, okay. Let me first. The panel discussion is. Oh, thank you, thank you. My computer has some faults. The second professor is Professor Wu Feng. He comes from Union Medical affiliate to Tongji Medical College, Huazhong University of Science and Technology. The role he has many many roles in our experts in our hypertension region. He is the member of German Cardiac Research Center and member of 2016 National Medical Aid Teams to Tibet and many roles in our area. Our question is this section discuss question is one. The one question is older hypertensive patient often faces polypharmacy and frailty. How do we strike the optimal balance between intensive BP targets and reducing pill burden side effects to improve adherence? The second question is, given the time constraints of clinical practice, how can we efficiently implement shared discussion making to transition patients from passive medication takers to active cell managers? The third, does early initiation of SPC enable rapid blood pressure control to build treatment confidence and help improve long-term adherence? Now, let us to discuss about these three questions, and we can also discuss more questions about this adherence, about the patients, and let's begin.
Okay. Thank you for the introduction of Dr. Cheng. I learned a lot and was truly inspired by Professor Weber and Cheng today. As we know, poor adherence to antihypertensive therapy is arguable by greatest obstacle to achieving blood pressure control. Despite potent drugs and clear guidelines, control rates remain poor largely because patients don't take their medicines as prescribed. Improving adherence not only lower blood pressure more effectively, but also reduce unnecessary dose titration, prevents cardiovascular events, and empowers patients to take ownership of their health. So actually, SPCs, single pill combinations, are already widely used in our hospital and have received positive feedback from patients. We hope that more SPC options will become available in the future. Let's return to the question raised by Dr. Cheng. So She asked, in older hypertensive patients with frailty and polypharmacy, how do we balance intensive blood pressure targets against reducing pill burden and side effects to optimize adherence? So in my opinion, and I read some publication from the latest trials, a sprint and older than 75-year subgroup and the Chinese STEPS trial converge on cardiovascular benefit from more intensive systolic control with acceptable safety where monitoring is adequate. And another study, HIVIT study, established the benefit of treatment itself in the very elderly. So residual uncertainty concerns the frail and cognitive impaired phenotypes underrepresented in these trials. I think home and ambulatory monitoring to characterize the 12-hour burden in particularly important in old patients, and the intensive vacation should be considered. With force, symptomatic hypertension or limited life expectancy shift the risk-benefit balance. And I think maybe Dr. Zhu has another opinion.
Oh, thank you. Thank you for Nili. Now we ask her the second discusser, Professor Zhu, and tell your opinions about this problem.
Thank you, Professor Weber and Professor Chen, for two outstanding lectures. I'm from the Wuhan Union Hospital Department of Cardiology. First, Professor Weber gave us the diagnosis. The hypertension control fails not because of our drugs don't work, but because of two obstacles on opposite side of the desk. On the patient side, no adherence, and he showed us it's not only how much medicine is taken, but the pattern. No adherence, the stop and the start pattern may be the most dangerous of the world. And our tools seems to is limited. It's questionary overestimate electricity box, drug box recording, operation rather than swarming. Chemical testing is object, but not a snapshot. In the daily temporal tactics, even in the excellent center, we most just asked. On the other side, the side of the physician in inertia, the American data, the Professor Weber side are solving. In the visits, the blood pressure remaining uncontrolled. Half the time, no life advice were given, and 60% of the times the prescription was left unchanged. Professor Chen gave us the treatment, I think, to improving the adherence. He gave us the impressive way to simplify the regime. Start with the combination therapy, SPC, preferring a single pill combination, so that control comes earlier, and the conflicts is built, and the daily decision becomes as easy as can be. I think we especially he introduced the SPC, the beta blocker combination with the CCB. Maybe it's a very good choice. It's very worth in evening, I think. I learned so much. And so for the discussion questions, the first one, the older hypertension patient often face the polypharmacy and the fatigue. How do you struggle? I don't think the intensive drugs and the low pill burdens is a true conflict, I think. First, we have to stratified by frailty, not by age. My father is 80 years old, but his feet is not frail. So a fit 80 years old and a frail 80 years old patient are two different patients. In the sprint cinema subgroup and step 12 show that the robust old patients benefit with the tire control just as much as the younger ones. But remember the sprint adherence analysis Professor Webb showed us what matters is not only how much drug is taken, but the pattern. The patient with the Feng Zhu adherence, too much 1 week, too little the next, had highest even rates, worst even than stable under adherence. In all patients, especially with the congestive impairment, erect intakens is exactly danger, I think, which is why involving caregivers and we here emphasize them matters so much. Secondly, and simplifiedly, consolidation, not dosed, not a medical dose, medical application, I think. A dual or triple as a single pill combination delivers guidelines level the intensity in 1 tablet a day. The Deutsche START study showed us the same molecules as 1 pill means better persistent and lower mortality. And let's not forget the low tech tools from Webb's list, pre-swapped multiple dose polybox. The patient simply checks whether the combination is empty, may reduce the homogenization, stop the unnecessary drugs. Is another part of simplified tool. And the drugs class matters. In the Northern Italy data, ARBs have the lowest discontinuation rates. So ARB-based SPC, I think, is not only effective, it's also easily region to stay on. Third, guardrails for old patients, I think, check the standing blood pressure at every visit. I would like favorite CCB-based combination with the lowest hypertension risk. In the frail, start low and go slow. And the pair even its accumulation with the medication recommendation. Encourage the home blood pressure monitoring, reasonable and be encouraged. As Professor Weber put it, my rule of first, for the fit old patient, aim for the target. For the frail one, aim to the safety regions, safety drugs that preserve the function. We are getting most of the way there. And reassess the person, not just the number at even at every visit in the clinic. And for the second discussion question, given the time's concentration of the clinical practice, how can we effectively implement shared decision-making to transition patients from the passive medicator takers to active self-managers? It's a very interesting question, and I think it's also let us start with the sobering numbers Professor Weber just gave us. In Europe, most of doctor-patient communication lasts only maybe no more than 5 minutes. And in the ESH survey of the 67 excellent centers, the only adherence assessments used in daily routines or just simplified ask the patients. So the question is not whether we have time for shared decision making, it is how we use those 5 minutes. Maybe in China, maybe also maybe no more than 5 minutes. My answer is we could redistribute the works. We could reduce the work across the time, across the people, and across the technology. Across time first, move our health education outside the consultation in the clinic. A patient who was watched a 3 minutes video or read a one-page leaflet before he visited arrive with the preference half point. Your minutes then go to confirm the touring, not lecturing from zero. And build self-management step by step, maybe one skill per visit. The first time, how to measure your blood pressure in home. Next, ambulance your blood pressure and recurrent. And second, what's the side effect happens when you take drugs? I think you can manage the step by step across in time. Next is the second is the across the people. The treatment and the health management is a teamwork. It's a team sport, I think. A nurse and the families can carry the training and hearings counseling. And know the families involved is one of the anti in Asia measures. Professor Weber's evidence actually supports the doctor's minutes are reserved for real decision points. China's hypertension specialist centers has showed how drug the pathway make the division on the labeled routine time. And third, I think, is cross technology. And here I like to widen the lesson because technology is no longer just about the SPC, not just about the monitoring. It's starting to change the treatment itself. We have the SPC, but it's not the it's better, but it's not the best, I think. Now we have the more tools and more biological drugs and ways to against the hypertension and also for the patient's adherence. For example, the new treatment, the Zilebrillion, a small interfering RNA against the AGT in the RAS system. One injection, we lower the ambulance, the SBP by the 14 to 70 millimeters in Cardio 1 study, and it could heal for the effect for half a year, about 6 months. And in our center in the Wuhan Union Hospital, and the Department of Cardiology, the chief of our center, the Professor Liao Yuhua, his teams has brought the world's first therapy, the hypertensive vaccine, which are against the AT1 receptor. This vaccine can teaching the patient's immune system to modulate the AT1 receptor, and one injection perhaps even one or it could affect 1 or more months. So so we think we for the secondary across the technology we now there is a trajectory is unmissable. The hypertension care now is moving from the prescribing chemical patients must remember to developing the durable biological program that the health system administer. So to sum up, perhaps the patients before the visit sharing the work across the hypertension management team during the visit, and let the talk knowledge, especially the new technology, are carrying the conversation between the visits. Okay, for the third discussion question, I think that's the earlier intonation of the SPC and the rapid blood pressure control to build the treatment confidence and help improve the long-term adherence. I think my answer is yes. And honestly, the Professor Weber's lecture and the Professor Chen's lecture make the case stronger than I could have. They list the region simplified as the first time intervention for non-adherence. Earlier SPC is simply to make the adherence, and to the both obstacle we hear about tonight, the patient no adherence and our own inertia. I think about it's true that about a quarter, the 3/4 of the patients need more than one drugs to reach the blood pressure target, starting with the one drugs and titrating for months gets us slowly to where the dual SPC gets last in the weeks. I think that is why the ESH and the ISH and the Chinese NGAI guideline all recommend the intentional combination therapy, preferably in a simply pill. And the low dose the combination usually means fewer side effects than one drug published in the maximum. And the Professor Cheng gave us a very good example, the combination of the beta blocker and the CCB. But the adherence evidence, I think, is the strongest part of the story I listened tonight. Adherence falls as pill counts rise. The SPC improved the adherence and persistence by routing the quarter of as the same drugs taken separately. And I think that which Professor Weber has emphasized that the sprint analysis showed factoring adherence is the most dangerous part of the work. One simply data type is left less room for the drugs holiday and catching us dosing. It is protects the pattern, not just the average. And the confidence looks is what turns pharmacology into behavior. Weber reminds us that hypertension as chronic patients feel nothing, so that motivation to take pills is weakened. It's weakened by the default earlier visible control, ideally on the patient's own home monitoring, supply the feedback that the disease itself never gives, prove that the treatment works, right when the long-term relationship is being formed. And on our side, on the physician side of the desk, first description that works leaves no room for the therapeutic inertia, and we saw in the data that Professor Chen gave us. So I think So I think this is my answer to these three questions. Thank you.
Thank you, Professor Zhu. You give us a good, excellent discuss the problem. Thank you very much. Now, our time is over. Now, let me. Oh, Professor Weber, you're on the line. I have one question to ask you. I want to know how about the clinical work. Can you do can you do to check the adherence of your in your clinic and how what methods do you use there? I want
No,
to.
that's a really valid question, and actually, we consider chemical adherence testing, so a drug concentrations in serum in a very few patients, but it's not it cannot be done in my hospital, so we have to send the tests abroad. So we do it only in a few selected cases. And we did it for studies, of course, but that's not the clinical practice.
In our clinical trial, some resistant hypertension maybe has a problem of no adherence with medicine, but the patients do not think so, and they may tell us, I have taken your medicine, but my blood pressure cannot control. What can I to do? This is some people. Do you have this some patients about like this?
Oh yes, we have. What I do regularly, actually, we have the opportunity to do to check the prescriptions in the pharmacy for those patients, let's say, who are fully engaged in our electronic health records, which is the majority, but not 100%, unfortunately. So I can check immediately within a minute if the patient ever refilled his prescription for, I don't know, an ACE inhibitor or whatsoever drugs in cardiology and in hypertension. So I think this is a quite simple, quite robust method, but unfortunately in Austria, not 100% of the patients are covered by these electronic things. And they also may disengage. So the patient may decide that his data are not visible, let's say, for the doctor. And then, of course, it's a problem. But of course, you can only check if the patient bought the medicine in the pharmacy, not if he took it. But the other way around, it works. So if he never bought the medication, then of course he cannot have taken them. Yeah, that's what we're doing.
Thank you. Very good method.
Thanks.
Thank you.
Okay.
Okay, our time is over. And first, we thank we very thanks for Professor Thomas Weber give us an excellent presentation in this time and tell us some very important method to how to control the adherence of the patients. And the Professor Ni and the Professor Zhu discussed many questions about the adherence in especially in China, how we treat the patients to improve the adherence of in our clinic, and now I am very thankful for everybody, every professor and every doctor who will listen to us this time. And thank you very much. See you next time. And on the other hand, I want to invite Professor Thomas Weber to can come to our hospital to give us excellent lecture next time. Thank you very much.
Okay, hopefully I can come. Thank you very much. Big pleasure. Thanks for inviting me here. Bye bye. Have a nice day. Have a
Bye-bye.
nice evening.
Thank you.
Bye bye.
Bye-bye.